So there are different types of glaucoma surgeries that are available for controlling intraocular pressure or eye pressure. The way I like to think about it is just simply plumbing. Everybody has plumbing in their house, and if we try and work our way through how we address plumbing, in order for the pressure in the eye to be maintained, you either have to control the amount of fluid coming in the eye or control the amount of fluid leaving the eye. So if we take our kitchen sinks, for instance, everybody has a faucet that lets fluid in. Everybody has a retainer or container or a sink that holds the fluid. They have a strainer over their kitchen sink, and they have the plumbing that is within the house. And then they have the public plumbing system that drains fluid out of the eye. So if I have to categorize glaucoma surgery, let me take the first set of surgeries that are usually lasers that reduce the amount of fluid the eye makes. That's like turning down the faucet. So if you have an obstruction where the fluid or the sink is retaining fluid because there's an obstruction to outflow or fluid leaving the sink, you can turn the faucet down. That's one of the ways we do it in different type of lasers, micropulse laser or cyclophotocoagulation. In that case, we're turning the faucet down. For other surgeries, more commonly, surgeries like mixed surgeries, the strainer over the kitchen sink can either be bypassed or stripped. And what we would do is you can actually make a hole in the strainer, as we would with certain procedures like a goniotomy or a trabeculotomy, where the strainer is actually completely removed. The other option that you can have is to have a situation where you have a strainer that's seemingly functional, but then you create an opening in that and plug it with something to hold it open. And those are stents and bypass procedures like iStent, for instance, the Hydros. Those create small openings in that strainer and allow fluid get into the rest of the drainage system. Then we have the other things that we can do. We have things like a trabeculotomy or trabeculectomy, or a drainage implant, which is actually just creating alternate pathways for fluid to leave the eye. It's very important to know that any of these drainage procedures that go through the natural or the normal drainage system, or the drainage system that is inherent, that is already there, we have to remember that in order for these surgeries to work, the rest of the drain that drains through the house and outside into the public drainage system all have to be functional. In the event that one way or the other, either after we have tried these procedures, we see that the drain is not picking up the slack, so to speak, that drain that's under the house or the drain that's public system, which we have in our body, those are collector channels, we call them that, episcleral venous system. We can ascribe those to the public drainage system and also to the drain that leaves beyond the sink. If those are not functional, then we have to create something else. Somehow we have to bypass the flooding that's going to happen if we can't empty the kitchen sink. And that's where procedures like a trabeculectomy or a tube shunt happens, where you either add something to the sink to drain it into a bucket or something else. So it's interesting that understanding plumbing helps us understand the different things we do to address high pressures and address patients who have glaucoma in treating them surgically.
There are certain things you need to be aware of. There is a risk, a lifelong risk for infection. And that's because there's an external drainage from the inside of the eye to the outside of the eye. And the actual numbers are about 1% per year, basically. But, there are certain things that have been modified with our technique, how we make our incision, what kind of anti-scarring medication we use, and how that anti-scarring medication is applied that have now minimized the potential risk for infection. But although we've minimized it, it's still a real risk that all patients that have undergone a trabeculectomy or any subconjunctival filtration procedure, such as a gel stent, need to be aware of. And so if you have what's called a bleb, and that's the area where the fluid is flowing from inside of the eye to the outside of the eye underneath the skin, it's called a bleb. And you'll hear your doctor say that on occasion. And if you have a bleb, then you need to be aware of the potential for an infection. So unlike your neighbor that has never had a glaucoma surgery, if their eye is red, you can kind of chalk it off to some irritation or maybe a pink eye or something. But if you have a bleb and you have a pink eye or an eye that's irritated or tearing, you need to see your ophthalmologist because that could be the first sign of an infection. If it gets worse, then the eye can get more red, more irritated, more tearing, more sensitive to light, and then you can have a drop in vision. All those are signs that things are getting worse. So what I tell my patients is you need to be aware of your eye, understand that because of this surgery, you're at a lifelong risk for infection. And if you have any tearing or redness or pain, you need to call your ophthalmologist immediately. Certain activities you should use caution with once you have had these kind of surgeries. I'd strongly discourage my patients from scuba diving, from swimming in a pool or a pond and opening your eyes underwater. Sometimes you can swim still, but use goggles that maybe not have that suction, but maybe the foam seal. Again, everybody has a different style, so make sure you run this by your ophthalmologist or your glaucoma specialist before you take these. But I'm very conservative with my patients when it comes to protecting them from infection, and I strongly discourage them from having any kind of activity where they are at risk for any kind of bacteria or dirt in the eye. So dusty environments, being outside around a lot of dirt and dust, swimming in a pond, opening your eyes underwater, all those things you need to be extremely careful of, as well as contact lens wearing. I usually don't like my patients to wear contact lenses after having a trabeculectomy or even having a bleb.
Sleep apnea is a common comorbidity or common condition that we see in patients who have glaucoma, open angle glaucoma. Now, why is that? What's happening in sleep apnea, unfortunately, is we stop breathing at night. So we stop breathing, what happens? Your blood pressure can go up and your oxygen levels can go down. We don't like that because blood flow can be associated, or lack of blood flow can be associated with glaucoma. So we think with the blood pressure changes, with the blood pressure going up and the oxygen going down, and then suddenly the blood pressure dropping, these changes in blood flow might change the oxygenation going into our eye, into the optic nerve, which could be a risk factor for progression. So when we think about patients who have glaucoma, who are still progressing, let's say where the pressures are well controlled in the eyeball, and they have comorbidities or other conditions like low blood pressure, or let's say CPAP, needing CPAP or having sleep apnea, we want to make sure those other systemic conditions are taken care of, because checking blood pressure, taking care of blood pressure, keeping the oxygenation levels of your blood consistent at night is important. Because we also have found in some studies that our pressure in the eye goes up at night, and our blood pressure can sometimes bottom out at night as well. When your blood pressure goes down at night, your eye pressure goes up, we decrease something called ocular perfusion pressure. Again, the pressure of the blood flow through the optic nerve, which can affect the oxygenation of the nerve and cause further damage as well. So it's very important, if you have sleep apnea, you're thinking you have sleep apnea, make sure you get it checked, and treatment as well, such as CPAP machines, can also help a great deal.